Right, everyone. Should we get started? My name is Alex Burkhardt. I'm the Director of Policy at the Centre for Social Justice. Very glad to welcome you all here this morning to talk about this subject, which is extremely close to the heart of what the CSJ does. And a lot of our work is focused on, as you know, pathways to poverty. We've done a lot of work on early years as well. But this is really a subject about the other end of life, that poverty that is often forgotten. The poverty not just of lack of resources, but also of lack of human company, of loneliness, of detachment from society. The work that we've done over the past few years has shown, rather depressingly, that 1 million people over the age of 65 report feeling lonely often or always. That on a typical day, there are over 300,000 over 75s who see no one, have no contact with anyone. And this builds into a picture of a forgotten age, which is the title of one of our reports. People who have been marginalised and left to one side by society. Because we don't focus services and resources on them as we should, we find that that we are creating problems further down the line that we need. That huge number of hospital admissions would be avoidable if only we took the right action beforehand. To discuss some of these issues, we have a star-studded panel this morning. Delighted to introduce on my right Dr. Dan Poulter, a former GP, now Parliamentary Under Secretary for Health. He has a great deal of experience in the field. Very grateful to you for giving up your time this morning. Penny Mordaunt, who had a glittering career in communications before she went to Parliament, including working on George W. Bush's 2000 campaign. Extraordinary experience. But also, since entering Parliament, has helped us set up our older age programme. We're extremely grateful to you for that. Then Tom Wright, who heads up Age UK. We also owe Age UK an enormous debt of gratitude for the sponsorship that they've given our two recent papers, The Forgotten Age and The Age of Opportunity, which have really laid the foundations for all of the work that we've done in the area. We're very grateful to you for supporting this event today, and for everything you've done in the past, and also for the great work that Age UK does on a daily basis. At the end of the table, Nick Carr-Brown, who is from Healthy Ardwick, a local organisation, part of the CSJ Alliance, which does fantastic work in this field. Nick, thanks so much for coming across the road and joining us today. Without further ado, I'd like to hand over to Penny to get things rolling.
Certainly. Well, thank you very much for organising this and for inviting me along. I'm actually the chairman of the all-party group on older people and ageing in Parliament. And although there are a myriad of all-parliamentary groups and looking at a whole range of issues that face older people, from integrated healthcare to dementia to transport, all sorts of things, our APG is really looking at what life is like for the whole person, looking at the international perspective, and really there to raise the bar, really raise aspiration, and challenge the way things have been done. I just want to briefly talk about two things, really. The first is about commissioning, and what are we actually commissioning for? When we talk about an ageing society, we quite often talk about the demographics. My local authority, for example, has budgeted for an extra 200 adult social care clients over the next 5 years because of an ageing population, and that's the kind of crisis that we always talk about. This demographic time bomb that's ticking away. What we quite often forget is what we're faced with currently. And compare those 200 extra adult social care clients to the 1,000 people that currently live in my city, Portsmouth. who have dementia and no access to any services at all. And those people, they tend to be poor, they tend to be isolated, they tend to have family living very, very far away. So the crisis that we often talk about is nothing compared to the real crisis that is existing now with us. And on my local patch, because I take a great deal of interest in this policy area, I spend a lot of my time shadowing the professors of older people's medicine in my local hospital, looking at people that are being admitted to hospital, why they are there, what could have been done in the system earlier to prevent them from being admitted. And that, I think, is really the key to this. It's about helping people live, have a higher quality of life, be healthier, be happier, be more fulfilled. You prevent people from ending up in hospital, you prevent their well-being from deteriorating, you reduce costs to the state, and you will have better commissioning. If we're identifying actually what the real need is and addressing it, which currently we're nowhere near doing, then only then, when we're realistic about the challenge that we have today, not just about planning for the future, will we actually start commissioning and designing services that are really meeting that need. One of the campaigns that I have helped launch over the last few years is the End to Loneliness campaign. And this is a really nifty idea that pulls together statutory and voluntary services in an area and enables them to work together in a much more constructive way. It provides the ability for people to be good neighbours. If you are a postman and you are noticing, you go to a front door and you notice things, you notice the milk's on the doorstep, or you notice the mail is piling up, or I hear this quite often, you're a checkout girl at Tesco's and the lady that comes in every week hasn't been coming in, or she has been coming in and she looks a right mess and she's in a terrible state. What do you do? What do you do if you want to be a good neighbour? And the End to Loneliness campaign, it's not prescriptive about what should happen, but it's enabled different communities to respond to those challenges in very constructive ways. It can provide a one-stop shop, a point of contact. If you're worried about an individual, you might not be related to them, but you can flag it. You can flag up that person's needs. And there's a sort of triage service that operates behind that, which will connect statutory but also voluntary sector services with that individual that previously will not have been identified and is in on no one's radar and in no commissioner's in tray. And there are lots and lots of wonderful schemes. I heard about one yesterday at the Red Cross run, which they've paired school children with an elderly vulnerable person. And what they do on their walk to school is that they check to see if a little card has been taken down from their window. If it's still up in the window, it means that person's in difficulty. They go to school, they flag it, the school then call out social services to go and visit them. So all of these things are actually helping us make better use of the current resources, statutory or voluntary sector that we currently have. And one of the projects that I'm going to be involved in this autumn will also help that, and that is to really articulate what we expect for all our older people who are in need in this country to have. The basics: access to a good social life, access to bathing facilities, a warm, secure home, nutrition, all those sorts of things that we can then judge whether a local authority is actually performing and commissioning for people in their local area. So my first message is really, let's be realistic about the need, let's identify that need. The tools are there already. Members of Parliament have databases in their office which can tell you where these people are. So we need to find better ways of using the tools we already have, and only then will the solutions arrive. Just to give you an example of one of the potential solutions that could come, I quite often have a lot of care home providers come and see me in my role as chair of the APG. And they've got wonderful care homes, they've got spas in them, they've got all these facilities. And then I ask them, can you open your care home doors to the local community? Can the lady who's 3 doors down, who's washing at a sink, come in and use your bathing facilities? the answer is normally no. So we've got to kind of rethink actually the resources we currently have and use them better. The final point I want to make is about money, because ultimately, if we want to provide good quality services to the poorest in our society, ultimately those of us that can afford it are going to have to make better provision for ourselves in later life. This is a huge challenge. If you think about the challenge we had over getting people to make provision for their pensions, you know, making provision for something that they are going to use later on in life. Imagine the scale of the challenge for, you know, making provision for something you might need later on in life. It's a really big challenge. We, I think, can be very proud of the progress that's been made on the Health and Social Care Bill, with the Dilnot inquiry and what follows. But actually, that is still not enough. And I think we really need to do more to enable smarter, tailored financial products that financial advisors would recommend, not just things that are just, you know, someone's got a nifty idea about a care ISA or a ring fencing equity in your home or whatever it is. Things that, you know, really do meet people's concerns. And I think we're entering into a really interesting phase, a very difficult phase and a very challenging phase in policy development, where we've actually got to come up with the rest of that proposition. It's not going to be easy, but I think, you know, we're at a situation now where we can really address those issues. So that's a couple of my brief comments.
Great. Thanks ever so much. Really insightful. Thank you. Tom, I wish.
Yes. I think integrating health and social care is the issue at the moment, and we're delighted to see this coming much higher up on the political and indeed the government agenda. We seem to have engineered over history a very dysfunctional approach to healthcare of older people, and we need to solve the causes and not just treat the clinical conditions that we're seeing across the country in so many ways. So we're very encouraged that the Department of Health are taking this issue more seriously. We're very pleased to see later this month the launch of the Vulnerable Older People's Plan, and we've been very pleased to work with the department and indeed with the NHS to discuss the implications of that. But what are the key issues out there for older people living with frailty? And indeed Penny's touched on some of them, but it's a long list of things that we could do so much better. Just to start, in terms of needs assessment, so few frail older people do have their needs properly assessed, or indeed receive a very cursory assessment. So much of the support that is now out there is reactive. Why isn't it more proactive with healthcare teams and GPs, despite the fact that by far the most frequent users of GP practices are older people with multiple conditions? And indeed, why aren't we practically identifying people before they fall into this multiple use and indeed exacerbated conditions that mean the A&E and hospitals themselves are often overwhelmed by the scale of that demand? Then we look at health professionals themselves, often a poor understanding, if you look at the training that medical professionals receive in what is their majority customer base now. We need to do so much more. And indeed, as we can hear time and time again, care is often unfocused, uncoordinated, no clear outcomes, just intervening when a particular clinical condition arises. And indeed, the quality of nursing and clinical care is often poor, and we know from our work in dignity and malnutrition how much more has to be done. All of this reflects that we have a poorly integrated health and care system, poor integrated support. So I have to say we very much welcome some of the discussions and initiatives. Indeed, just today, the Secretary of State's focus on extending the opening hours and the coverage of surgeries, going to an 8 to 8, 7 days a week coverage, is a very good example of some of the improvements we need to make to better support that. So that's really the first thing I wanted to touch on. The second thing I wanted to touch on is that there are much better solutions out there which are being demonstrated and indeed include the voluntary sector. I think there's a tendency to look at healthcare as a predominantly NHS-driven affair, when we know that we need to engage much more broadly, and you'll hear more from this from Nick in a minute. We need to look much more broadly at the health and well-being of our ageing populations. So we've been proving this around the country by taking an integrated approach to healthcare, and we call this an integrated care pathway. It's not new, this has been going on for decades, but I think now there's an appetite, there's a recognition that we can't go on treating older people in the silos of the current NHS construction. And our models are well established and delivering great results across the country. And what we do is we sit down with GP practices and work out who their most frequent users are, which is often the same old people coming in and out. And then we put in place a guided conversation with those old people, and we sit down and say, what is it that you want out of the health and care and support that you get? What are the outcomes that would change your life? And then we put in place a volunteer that works with them in an integrated team, including the local authority in terms of social care, the GPs, the district nurse, a fully integrated approach to addressing the needs of these frequent users. And this approach, this multidisciplinary care team, the impact on these frequent users of our healthcare system is totally transformative, not just in terms of the quality and the mental health of those old people that we support in this way, but a massive reduction in hospital admissions, and a huge improvement also in the morale of all the workforce involved, from the GPs to the nurses, right the way through to reductions in A&E and transfers through ambulance, and indeed people ending up in hospital. So these models are out there, they're well established. We just need to find a way of breaking through the complexity of NHS budgeting and NHS systems, and recognise that the solution lays not just within the NHS itself, but in a much broader approach, and making health and well-being boards much stronger in that capacity. So we urgently need to expand and develop these solutions, given their proven effectiveness. Really, the last question for me is, what is the most important policy solution? Well, it is being patient-centric. I know it sounds a bit obvious, but simply looking at the patient and working through what their needs and wrapping around them both the medical, the clinical and the social support that is already out there in a coordinated way will transform the outcomes and reduce the failings of our upstream interventions, which means that far too many older people are ending up in A&E and in hospitals themselves for far too long. And of course, our whole system financially drives people into hospitals when, of course, we know much better support in the community, in the homes and in GP practices. So we welcome Dan and the Secretary of State are great advocates of this approach, but as we all know, transforming the NHS into this approach is a big challenge. But this is the single most important policy issue, which will affect both the financial and the social outcomes of the current way that we approach healthcare in this country.
Nick.
I'll stand up if you want to hear me if I'm down. I'm Nick Cobbown. Our patch, if you've got a little break, you just walk sort of 5 minutes that way, and you hit lovely buildings like the Aquatic Centre, Manchester University. That's the edge of Ardwick on that side of Oxford Road, and then you just walk a little bit further and you're actually in Ardwick, which is the 4th most deprived area in Manchester, the ward, and the 29th most deprived ward in the country. About 15,500 people, quite a big Chinese population there, 39 language groupings, 3rd generation unemployment, and in West Gorton, which is right on the far side, you're right in the most sort of 1% top most deprived areas in the country. A very sort of diverse area. We're in walking distance of 7 major theatres, 2 major football stadiums. You know, it's amazing if you see the contrast between the wealth and poverty. And there we've got 3 major hospitals in Ardwick, you know, employing thousands of people, but very few people out of Ardwick. University, very few people are employed from Ardwick. And so we've got about 2,500 people unemployed out of that 15,500. About half of those are on sort of sort of type benefits, just to give you a little potted history. We're a charity that's been set up. I sort of set it up with local people. We have 3,750 members now, and it's funded mainly through lottery, a little bit of money from the council and other pots that we get. So what do? Well, we set ourselves up to try and get Healthy Ardwick out of this deprived status. You know, we're sort of saying, well, actually, all these people around us can't do it. So if we live here, and I've lived in Ardwick for 35 years, if we can't do it, then something's going wrong here. So local people are determined to actually make a difference, and we work in a very holistic approach to all ages. So from little 0 to 5, right way up, to if you're 100 or 106 or whatever. And we work on the main themes that would make up the index of deprivation, so environmental issues, health issues, jobs, education, all sorts of things. So you find us doing loads of things. We have our own newspaper. Why? Because the Metro and the Manchester News don't deliver in that area. So we've got all these lovely services around. You wouldn't believe it, but based in Ardwick, we have all the drug prevention people, we have the mental health team, we have everything, but nobody locally knew anything about them. None of those services were really delivering to anybody in Ardwick. So the newspaper is the conduit between the two. For £800 a month, we deliver a Metro-style newspaper into everybody's house. Every school child gets one. It gives them the opportunity to get the information. We can't do the whole lot. We're just going to go and look at the over 50s side. So our cut-off is over 50s. I know some charities work over 60 inside. That's why they work with other people. We work over 50s. Why do we do that? We want to engage with people before they get to the point of being too old to engage with us. We want to get to know them. We want them to be able to walk into our luncheon club and know this is a safe place to be. To walk into our walk-in centres. If you look at the age of opportunity, there's 3 or 4 ideas that were coming from our project. And one of those is to have these local walk-in centres. So we use churches or mosques or Victoria baths, and we create a nice environment where people in walking distance can walk in any time of the day. They don't have to fill in a form. They don't have to fill in a 15-page questionnaire before they get into our job club. They just get sort of family, fatherly help. Our job club, which is about 600 or 700 people have gone through that now, more people have actually got a job than any other job club around us. Virtually no one has been referred out of our job club to anywhere else, because all they needed was their CV sorting out. They need someone to sit down with them, maybe check the spelling. If you're a dad and you've got a son or a daughter, you'll have probably done that with them. And that's all we are doing. And yet we get criticised by everybody in the job club scene because we're not filling in the forms. We're not taking the national security numbers, but we're getting them jobs. And at the end of the day, and they're not being put off by, why are you taking all this data? Why do you need to know if I'm on benefits and all the rest of it? And so that's the sort of culture we've got, sort of a paperless thing. So somebody can come in that's over 50, and we'll talk about Pat. They like me to talk about stories, real people. So Pat, she came in, she saw an advert for going on holiday with us. So Pat rang us up and she said, well, I can't walk anymore. And, a West Indian lady. And so we said, fine, we'll give you a volunteer, they'll just be with you all the time, we'll find you a wheelchair, come with us. And the first day, I ended up being the person with Pat for the week. And it was on Conway Bay, sat there in tears, she was, because nobody had ever taken her out for the last 20 years. We didn't know this, you just get this lovely personal relationship with somebody. We discovered that 20 years ago, she used to go to one of the local churches, but the link was broken and no one was picking her up. So we just arranged that again. So now Pat, who's a brief story, Pat now, she's been learning English because she couldn't read. So she's been on a Manchester Education course for the last year. She goes to 2 or 3 weekly meetings and sees people. She starts to walk by herself again. All right. Her hospital appointment's down, her blood pressure's coming down. And all that is just because she's had some contact with real people. There's somebody ringing her up, somebody knows about her, someone's checking up, someone's picking up her work. And her English and her confidence is improving. And a lovely scene the other day was we got a man who's 42, just come in, can't read, and the rest of it. We had Pat, she's a Christian, so Pat trying to teach him how to read, reading him Psalms that she's now learned how to read. And that's a lovely picture of the community in action. We have loads more stories, can't tell them all here. The biggest problem we have, you know, we're little, and we try not to have a big admin fundraising base. So to fill a lottery bid funding in, it took me a year to do our first one for $500,000. Everybody said we couldn't get it. So that's our problem. How do we get this money and keep filling all these stupid hoops we have to go in? I have virtually a full-time person keeping up with the monitoring for the lottery. We have like 3,000 bits of signed bit of paper and they've got this up. You know, but what we do with a little bit of money, we can change people's lives. So how do we break through that? How do we get this money down without us having to go through all these loops? Where do we get the people that will understand that if you ask somebody in this age group about well-being, like question 1, do you feel that your well-being has improved since you've been on this trip? And they go, what? What does that mean? You know, all the stuff we've been asked, or the Webster scale or effort, it means nothing to the people we're dealing with. And everybody that we deal with is different. So I know there's people that have cut themselves off from society deliberately. They don't really want to go out. You know, I've got people that are trapped and they're isolated. The way we start to define them is by using police and stuff like that. You read about the reports. They come and knock on doors with us. The doctors won't get involved with it, but the local PCSOs will come and knock on the door. And they'll say to the person, this guy's okay. You can let them into your house. You know, they'll be nice to you. And we get a lot of referrals that way. But then, you know, that person has the right to decide what their version of loneliness is. You know, and we would say, we want to be able to sit down with that person, not do a baseline assessment or a needs analysis necessarily, but say to that person, well, what would make a difference to you? Can you describe in 3 months' time, if you had a magic ball, what would be the difference? They might say, well, it'd be nice to see my children, you know, once a week. It might be nice to go to church once a week. Others might say, oh, I want to be out every night. You know, but whatever it is, they're setting the target, and we can come back in 3 months' time and see if we together we've helped them meet that. The most exciting project I've been involved in, which has been disbanded, heaven knows why. We in Manchester set up a little mini task force, a really good guy, you know, running it. Every agency was part of that, including the voluntary people. 20 people sat round a room. They were given 5 streets, 120 houses. And the idea was that somebody would take the lead. And where the voluntary sector led, knocked on the door, said hello, yeah, got used to it, that those people then signed up for help. And they got the help. They got all these 20 people. And so we could go back to these 20 people from the volunteers and say, Mrs. So-and-so can't read, the gas bill's this, and whatever. And these people could solve those problems. We saw 25 families radically change within 6 months. And that is a really exciting prospect. And within that there's old people. But within our estate we could see real change from drug addiction, from mental health issues, from all sorts of problems. And those are the sort of things we'd like to see. But the biggest thing we'd like to see is some legislation or something that breaks this barrier between doctors and statutory services working with little organisations like us. They respect Age UK, yeah, but we're healthy, aren't we? We're, you know, local people down the road. Why won't they share the information with us? Why won't they tell us? Why won't they send our leaflets out? You know, and so that's the sort of thing we'd like to see change.
Thanks, Nick. Really inspiring stuff. Thank you.
Thank you very much. And we've heard a lot from the previous speakers, and in quite some detail, and absolutely rightly focusing on the need to break down silos in the public sector and to promote greater integrated and joined up working. And I have got some reassurance from Nick on that last point. Thanks to the legislation we introduced with the Health and Social Care Act this year, that came to House in 2012, we now have a framework in place which local commissioners, local CCGs can, if they want, commission what they consider to be the best service for the needs of patients. So it's given a much more proactive opportunity for the voluntary sector to engage and provide services for the benefit of people in a local area. There's still work to do on the procurement process. It's very difficult, I think, for many organisations to get through the morass of NHS procurement forms, and we're doing some work with NHS employers to make sure we simplify that, and that's an important piece of work that needs to be done. But there is now, for the first time, a real opportunity, which our legislation put into place, to recognise that the voluntary sector has just as important a role in potentially delivering high-quality services to local people as the NHS does. It will still be an NHS funded service, publicly funded, but there's a real opportunity for the voluntary sector to be created by that. But what I thought I would do is talk a little bit about the context of what we are talking about. First of all, the integrating health and social care for the poorest. Now, why are we focusing on the poorest? I know the CSJ are focusing on the poorest because that's your raison d'etre, but actually there's a very good reason why, as policymakers, we should also be focusing on the poorest. Why healthcare commissioners should also be focusing on the poorest in society, because we know if we get it right for some of the poorest and most vulnerable groups, we actually can create give those groups better life chances if we intervene in the early years. We also make sure that we reduce the cost and the burden of those groups on statutory services. So it pays the exchequer back. If we can get it right, we get the commissioning processes right, then actually we reduce the financial cost. And most importantly of all, we actually provide a much better human quality of life for some of the most disadvantaged and vulnerable people. So for all of those reasons, it's right that we focus on the poorest. And I thought it would be worth giving a little bit of context of, from an NHS perspective, before we talk about the need for integration, which I'm going to come on to in a moment, if you like, the financial background to the challenge that we face. And David Nicholson, the Chief Executive of the NHS, in 2009 sent to the previous government a challenge that just to stand still, the NHS, just to stand still, given a financial settlement that assumed 0% financial growth in real terms once inflation is taken into account, the NHS needs to make 4% of efficiency savings year on year. And the reason for that, as Tom very rightly outlined earlier, is because we have a lot of older people who are living longer, which is a very, very good thing. We have a lot of older people who are living longer with multiple disease, with diabetes, with dementia and heart disease, and rising patient expectations as well. So we need to be able to find the money in the system to more money to the front line, and where possible, save money on back office services. So that was the challenge, that we've got to find out and free up more money in the system. Part of meeting that challenge is about how we deliver services and transforming the way we deliver services and better integrating health and social care, and I can come back to that a little bit later on. But we have seen that investing in the making sure we get it right for some of the most vulnerable and poorest groups also has shown how integration really works. Actually, it's a way of delivering services in a better way. And a good example of that is in the early years, that we've done a lot of work investing in family nurses for teenage mums, and that's 16,000 families will be benefiting very soon. And that gives targeted help and support. It's quite an extensive intervention per family and per child, but it gives targeted help and support to some of those vulnerable mums. The mums we know will struggle sometimes with the challenge of parenthood, sometimes will struggle to get back into education and training and employment later in their lives. And we've seen that by investing in a workforce to support that group, it gives each and every child a better start in life, it supports maternal-child bonding, and those children tend to go on and do well in their early years and then later in life. And there's a lot of evidence from America that really works. So actually investing in a group that is particularly disadvantaged is the right thing to do in human terms, but the savings that are made from what is quite a substantial £3,000 upfront investment per family is paid back 10 or 20 times over later on, from the fact that we have less domestic violence, we have much less school absence rates, we have parents who are going back into education, training and work, and helping to be good providers for their families. So that upfront investment pays itself back. And it's absolutely true as well that if we're looking at the issues that we're talking about today, investing in older people, we have to take those examples and look at those, and look at the fact that when we're talking about the issues of social isolation, malnutrition, and long-term illness, it tends to be, in terms of if you look at the statutory services, there are certain groups that keep in, if you like, regular users of those services because they're bouncing in and out of hospital, because of the fact they're not getting a holistic, joined-up, integrated approach to their care. Well, the fact they're bouncing in and out of hospital is not good for them, it's not good for their families, it's not good care, it's also incredibly expensive. And I was speaking to a hospital chief executive recently who told me that he was tracking data, and there were 6 older patients in his hospital who had been in and out of hospital in the past 3 months no fewer than about 120 times. So that's 6 patients going in and out on average. If you average that out, each patient's going in and out 20 times. Now some of those, there were in a couple of cases, I believe, substance misuse issues as well. But it does show that some of the most vulnerable groups, if we get it right for those groups, by transforming the way we care for them, that actually reduces pressure and frees up more resources for everybody so we can better look after older people. So it's a very good economic argument as well as a human argument why this is the right thing to do. So if we look at what are the solutions, and one of the key challenges we face in healthcare is the fact that we have a system that is a reactive system. We are very good at treating heart attacks, treating someone with a stroke, and we're very good at that reactive care, but we haven't always seen the need to, historically, to invest upstream to make sure people perhaps don't have that heart attack in the first place. And a very simple example of this is that we're very good at fixing hips and doing hip replacements in hospital. Very good at doing that, and we have very good results by international comparisons in terms of the quality of our surgeons and our surgery. But the question is, can we stop some of those people from falling over and tripping in the first place, breaking their hips? And that's why it's important we do transform and integrate services. Because if we can have a more holistic approach, perhaps to getting the right housing in place, with the right lighting, with grab rails, very simple early interventions that will make a real difference. That will mean that someone may be able to see their way up some steps and see the way along a path, have a grab rail in the right place, that they might not fall over and break their hip in the first place. Obviously, that saves money, but actually I'd much rather see people prevented from having bad things happening to them rather than be investing in picking up the pieces when it does. Of course we need both, but the challenge in transforming services, particularly for the most vulnerable, is that upstream investment, and that's why integration of services is so important. Now there are issues here, of course, for the workforce, and Tom quite rightly alluded to these, and we need to move away from some of the silos that exist in workforce. And in the early years, that's very obvious with child safeguarding issues, and that we have health visitors, which will soon be commissioned by local authorities who currently work for the NHS, and looking at the fact that what we're looking after is a person with needs. That person doesn't recognise the fact that it's an NHS member of staff looking after them, or a member of staff from a care home, or someone from the voluntary sector. We need to actually look at a workforce that potentially, a statutory workforce that can potentially move across organisations and adapt to people's different care needs, and that's a key part of doing that, and that's part of the forthcoming mandate for Health Education England that I will be putting forward, which is looking at how our workforce can be adapted to look at changing care needs. The second part of this, though, is also about the commissioning process and tariffs, because traditionally the tariff system in the NHS has reinforced the institutional silos that exist. The fact that you have a payment by results tariff in a hospital means that the hospital is paid for activity sometimes, rather than necessarily working proactively with social services care or with community healthcare providers to encourage upstream investments. We're already underway changing those tariff systems, putting in place changes to the tariff systems on issues, things like stroke care, focusing much more on the rehabilitation, the important part of reablement and rehabilitation on stroke, rather than just the treatment of acute stroke itself. But finally, what we need to see is actually making, as Tom said quite rightly, these health and wellbeing boards that we have now very effective. For the first time, thanks to the 2012 Act, we have at a local level, in every part of the country, health and wellbeing boards run by the local authorities who are closest to their community, right that they're running these services, where you have the local authority, the voluntary sector, the NHS and housing, other providers all coming together with a common purpose of improving the health and well-being of that particular area. And it's not for central government to dictate what the health and well-being may be in Kent or in Suffolk or in Bradford or in Manchester here. It's for the local community to work and listen particularly to the voluntary sector about what some of who have gotten very, very close to the local community needs, about what those priorities are. And very clearly, a ageing well and providing dignity in elderly care is a priority for almost every health and wellbeing board, and that's something that we are quite rightly seeing. So how do we drive that integration? And what the government's done, what the Chancellor announced, was a 3.8 billion integration fund to make sure that the health and wellbeing boards work collaboratively. So all those agencies are encouraged to work collaboratively, not focusing on the different financial drivers within their own institutions, but putting the money together to promote joint payment and commissioning of services and focus much more on the needs of individuals and more personalising care. And if we're going to get this right, we know that the evidence from the early years intervention shows that if we get personal care as a priority, then we get it right, not just for everybody, but in particular for some of the poorest and most vulnerable. Thank you very much.